It's not unambiguously bad what happens in winter every year. There is a cost. We could have a lot more extra capacity, but we would have to either come up with a way where we can have really flexible capacity. Some firms can handle a lot of extra capacity around Christmas, the post office, for example. There are ways to do that. But, lots of that might be quite difficult. And if the choice is between having permanently higher capacity all year or having a tough winter every year, well, we know British governments for a long time have chosen the latter because it would be very expensive to have a lot more permanent higher capacity.
Hello and welcome to the IFS Zooms In. I'm Helen Miller, Director of the Institute for Fiscal Studies. Today we are talking about the NHS. The NHS has a special place in British culture. Many people see its existence as a point of national pride. It also has a special place in the national budget. The NHS is huge. It is by far the biggest public service in England. It's set to cost over £200 billion this year. To give you a sense of scale, that is more than we spend on education, defence, transport and justice all put together. It's the equivalent of £3,500 per person. It really is hard to overstate the scale of the NHS within the British state. And yet, despite our love for it and despite the money we've poured into it, there are no shortage of concerns about how the NHS is working in practice. And therefore, it was no surprise to see the incoming Labour government set a pledge to improve the NHS. And in particular, they focused on waiting times. Those waiting times had shot up since the pandemic and they were growing before that. However, there have been limited progress since Labour have come into government. The NHS waiting list currently stands at 7.4 million, for example, compared to 7.6 when Labour came into office. That's hardly stellar progress. More generally, the NHS continues to perform worse compared to pre-pandemic across many areas. And that poor performance is despite an increase in funding and despite the fact that the NHS employs 250,000 more people than it did in 2019. So, what's going on? Are there any signs of improvement? Is the NHS doomed to continue to have poor performance forever? Is something going wrong in the system, or are the wrong decisions being made by the government? Joining me to discuss those questions and many more are my colleagues here at IFS, Ollie Harvey-Rich and Max Warner. Welcome to you both. We've decided that we're going to kick today's discussion off with talking about winter, and in particular how the NHS does in winter. I'm old enough now to remember that there are two annual things that happen in winter. One is Christmas, and the other is this annual issue where the NHS always has a problem where it might be about to fall over. This winter was no different. The NHS said itself that it was facing a worst case scenario, and the Health Secretary, Wes Streeting, said the current situation was, quote, probably the worst pressure the NHS has faced since COVID. We had the surge of flu, we had resident doctor strikes. So, Ollie, what is going on at the moment? Why is this winter so tough for the NHS?
So I think even heading into this winter, there was a lot of reporting that the NHS was under pressure. We had lots of headlines of corridor care, of queues outside ambulance departments, quality and waiting time standards not being met. And then on top of that, as you say, this winter we saw a flu surge in December and resident doctor strikes just before Christmas. And so that means, perhaps unsurprisingly, hospitals are pretty busy at the minute. But I don't think we should overstate things. Although things are bad and things are busy and not meeting targets in the NHS at the moment, I think it's now looking unlikely that this is going to be worst case scenario or a worse winter than we've had for a long time. Flu cases now are looking a bit lower than they were in December and much lower than they were at the peak of the flu season last year. There's some evidence that the NHS is managing to deliver more pre-planned activity through resident doctor strikes than it has previously, although not without other costs and disruptions. And across a range of other indicators that we might come on to, is looking like, although still bad in lots of cases, lots of things in the NHS are starting to look slightly better than they have over the last few years.
Okay, so maybe it's not the worst winter we've ever seen, and maybe it's not as bad as maybe some people feared before Christmas. But Max, we are in this cycle where this happens frequently. Most winters we have this surge of concern about the NHS. I mean, is that just how we've rigged the system up? Is that just kind of a part and parcel of how we design the NHS?
Well, winter for many countries, like the UK, is associated with increased pressure on healthcare systems. There are some, things like flu, not just flu, but notably flu, that are more prevalent at winter, and that does increase demand for healthcare services, particularly some areas. That is just a natural part of the world we live in at the moment. Now, the question is, why does that always end up with big challenges in the NHS? And I think the simple way to think about this is we, in recent years, but for quite a while really, run the NHS pretty hot. By that I mean we're always pretty close to capacity. Most staff, most beds, most of everything is already being used. So when we have a big surge in the number of patients with flu, for example, there aren't just spare beds they can be slotted into. Instead, we need to kind of divert activity and divert resources away to those patients, and therefore other things like maybe A&E waiting times get longer, maybe patients get some of their care cancelled. That's the kind of inevitable consequence of running the system relatively hot and then having this annual winter pressure.
I think it's worth highlighting that to a large degree that's a choice, right? So all systems are rationing healthcare in some way. And there is no system in the world that's providing the maximum amount of healthcare people would be able to consume or would want to consume. Other countries do it through price mechanisms, for example. We have more of a quantity rationing where there's waiting lists or there's restrictions on what kind of care you can get. So I think it's important to almost talk about, like, we shouldn't be expecting that there's a world in which winter was always completely easy and we hung around with lots of extra capacity and there was no extra pressure at winter.
Yeah, I think there's a cost. It's not unambiguously bad what happens in winter every year. There is a cost. We could have a lot more extra capacity, but we would have to either come up with a way where we can have really flexible capacity. Some firms can handle a lot of extra capacity around Christmas, the post office, for example. There are ways to do that.
Mince pie creators.
Mince pie manufacturers, exactly. But, lots of that might be quite difficult. And if the choice is between having permanently higher capacity all year or having a tough winter every year, well, we know British governments for a long time have chosen the latter because it would be very expensive to have a lot more permanent higher capacity.
Let's pan out a bit from winter. Ollie, big picture, how's the NHS doing since the government came to office?
I think waiting lists are maybe a good place to start, given the NHS is just such a large, complicated organisation that kind of delivers GP appointments and kind of cataract surgeries and everything in between. So on this kind of waiting list target, as you mentioned at the top, this is one of Labour's big priorities, kind of not just for the NHS, but for public services more broadly. It put it as one of its kind of main missions, main milestones immediately after coming into office. So we're talking here about waiting for pre-planned non-emergency care. So think of things like a hip replacement or an outpatient appointment. The headline target here is that patients shouldn't wait any more than 18 weeks from being referred by their GP to starting their course of treatment. This hasn't been met for a very long time now. I think it was late 2015 or so that this was last met. And when Labour took power 18 months ago, that was sitting around 55 to 60% of patients being seen in that target time. Things have got slightly better over the last 18 months. So I think as of the end of October last year, this was about 62%. But progress has been pretty slow. And I think, as you mentioned at the top, the number of people waiting has come down very gradually and probably more slowly than lots of people might have hoped or anticipated. Partly this is just because we've got such a large backlog and this is a pretty ambitious target that hasn't been met for a while. I think it's fair to say that things are getting better, but not particularly quickly, and we're pretty unlikely to see this kind of target performance being met by the end of the Parliament.
But just on that particular target, on this kind of pre-planned elective activity stuff, is it possible the government could meet its target? Is that still a possible outcome?
So waiting times are in large part determined by kind of how many people join the list for care, how much capacity the NHS can provide, and then how the NHS decides to treat those people. It's possible that we spend the next 3 years really focusing on these kind of pre-planned elective activity. And if demand is also not too high, it's possible that we could kind of blitz through the rest of the list and get back to where we were by the end of the Parliament. But it's worth noting that this would come with some other trade-offs. It would probably mean either spending lots more on the NHS overall with some fiscal consequences, or deprioritising other bits of the system, like emergency care that we were talking about is in the headlines a lot of winter, or primary care and other things that people might be less willing to deprioritise.
Yeah, and that's important, right, Max? So it's possible the government can meet its specific target, although not necessarily likely, but possible. But that particular waiting list, although obviously some people, especially if you're on the waiting list, will care a lot about that. But I think the bits of the system that people also think about, maybe they think about even more, is GP appointments or ambulance waiting times or A&E or some of the other bits of the system. How are they doing?
That's right. And I would say, it is very noticeable that the government have very much focused their headline ambitions on those pre-planned waiting lists. Now, there are millions of people on that list, but a lot of the NHS is not covered by that. So I think the broad story is actually very similar, though, for these other areas. So let's take emergency and urgent care for a minute. There, again, we see when we think about A&E waiting times, ambulance waiting times, things are a little bit better than in recent years. You might remember then 2022, we had a terrible winter for ambulance waiting times with incredibly high. We've moved beyond that. But many people are still waiting very long times. Many people are waiting, more than 12 hours in A&E departments to get a hospital bed, for example. So some improvement, but we're still far from where we want to be, where the targets are, where we were pre-pandemic. Thinking about kind of primary and community care, so this is things like GPs, but we can also think about mental health services, district nursing services. It's hard to kind of capture fully performance there. Traditionally, there's been less of a focus on big, broad targets like we get in hospitals. But again, it seems that that's a pretty similar pattern. Maybe some improvements, people report being a little bit more satisfied with their GP over time. But there are still some real big challenges there. Long waiting lists for diagnosis, for mental health treatment. They're still challenging often to access primary care, so getting a GP appointment. So some progress, but big challenges remain.
And perhaps it's worth linking that to what we said a minute ago about like the quantity restrictions, what the government's trying to do, because it's interesting, isn't it? I think we've now all benchmarked what currently is happening against pre-pandemic. Like, can we get back to that point? And obviously that'd be great. But actually, pre-pandemic, people weren't super happy either. We were talking then about actually there are long waiting lists. People aren't happy with how quickly they can get their care. So in some sense, even getting back to there wouldn't be good enough for a lot of measures. But also we shouldn't expect zero waiting times. So what do we think about what would a good waiting list look like?
I think that's exactly right. Pre-pandemic is a convenient reference point, a convenient baseline to think about, but it is a pretty poor one. Performance in the NHS was deteriorating over the 2010s, broadly defined. And for lots of things, ideally things would have been getting better for a number of years. So just getting back to where we were pre-pandemic isn't ideal. But you're right, when we talked earlier about rationing, every healthcare system essentially has to ration in some way. You can think about it just any good, let's take a chocolate bar, for example. If chocolate bars were free, people would take a lot of chocolate bars, right? That's basic economics. I think most people listening can think that through. Healthcare actually, in some sense, in the NHS is at least financially free for most types. So we would expect people to want quite a lot of it. But healthcare isn't actually free for society. We have to deliver it. Now, we don't have a price mechanism in the UK. Lots of other countries do. But we don't have that price mechanism to ration access. But we need to do something. We do have resource limits. The government doesn't want to spend most of GDP on healthcare. And so we use things like waiting times, waiting lists, but also, clinical decisions about who does and who doesn't receive treatment, decisions by economists about which treatments we're going to fund and which ones we're not. All of this is trying to ration access. And that rationing is important. As you say, the optimal system here is probably quite unlikely to have zero waiting times.
And obviously there'll be pros and cons to using kind of the types of rationing the NHS uses versus a price mechanism. But just on the waiting list, so you mentioned there are other ways we ration that, the government basically decides which types of care to offer and which not to offer. They'll decide which types of people and which kind of cases to offer and not. But taking a waiting list, do we know anything about how successful that is in almost getting care to the people who need it most? So are the people, obviously there's kind of acute care, there's A&E, your leg's just been chopped off or something, you need immediate care to stay alive. But then within the elective waiting list, there'll be lots of people with conditions that are really hard to compare in some sense. Do we know much about how waiting helps people with the most need get there? Do people drop off if they'd like some healthcare, they don't really need it so much, they drop off? How much do we know about how good waiting lists are?
So there's a few different angles to this. I think the first thing to say is the waiting list is not a kind of passive thing where people just join the end of the queue and then they wait and then they get to the front of the queue for two kind of reasons. The first is hospital and clinician behaviour. We often talk about long waiting times for this pre-planned care, people waiting more than a year, more than 18 weeks. But a lot of people are still receiving treatment in a couple of weeks. For the urgent cases, things like cancer, but other things too, on that list, clinicians are making decisions, they are prioritising patients. And that's in some sense why we often end up with a really long tail of waiters, either because they're very complex or because they are somewhat lower priority. So there's prioritisation going on there. But you're right that patients might also respond. There is academic evidence from the UK and other countries that longer waiting times will put off patients. And that might be quite different for different types of groups. Now, you might theoretically and ideally hope that patients with the greatest need will be the least put off. But just like a price mechanism, there could, for example, be socioeconomic differences there. And, even simple as, we have a private pay market. People with sufficient resources can not wait in the NHS and private pay. But more broadly, people might value differently how long they spend. And I think the final thing to mention is waiting times as a way to ration have another kind of disadvantage, which some types of healthcare can get worse while you wait. Not everything, there's kind of mixed academic evidence, but waiting in pain or for a long time has other kind of well-being costs really on patients waiting.
Okay, so before we move on to kind of why there are problems, I mean, we should talk about quality of care too, right? So we've talked about the waiting list, and in some sense, that makes a lot of sense. It's a thing you can measure them over time, and you can keep a handle on them. But what we ultimately care about is not that. We care about how many people are alive, how long they live, their quality of life. So what do we know? And I think I know the answer is it's difficult, but what do we know about how kind of quality of care is changing in the NHS?
I think you're right to start with it's difficult. One of the reasons that we focus, both we as, say, researchers, but actually indeed the government, focus on these operational measures, and they do matter. The ability, the ease of accessing care does matter for patient health, is because they're quite well defined and measurable. When we think about the impact of the NHS on people's health, that is something very difficult to quantify. It's very different for different types of conditions, different patients. That doesn't mean it doesn't matter, and it doesn't mean that policymakers aren't focused on it. There's a lot of focus on patient safety, but it's often done through channels that maybe we as economists don't think quite so much about. So, for example, there's a lot of investigations and in standards for doctors and hospitals to ensure that they are performing well. There have been some high-profile scandals, of course, there too. But we should actually be somewhat careful about using things like life expectancy, for example. Often that's used to compare country by country. Obviously, we do care about the quality and length of people's lives. That's incredibly important. But healthcare is just one part of that. So it's a little bit hard to draw kind of big conclusions from that.
Yeah, so you could have people doing badly, but not because the NHS per se, but because other things in their life are going wrong. So let's talk about what would it take for the NHS to get better in some sense? So the NHS is getting a bit better, although probably slower than this government would like. Although, every government wants to make things go faster. Let's unpack what could be driving this. Let's start with the money, because the obvious thing that some people say is, well, hang on a minute, you just need more money into this system. Wouldn't that help? But the NHS has been prioritised over and over again, Max, including the last spending review. So just paint a picture for us about how much money the NHS is sucking in.
So the NHS is really the golden child of public spending. Essentially, as far back as we have good data to look, you will find a consistent pattern that when the government decides to allocate money, it's going to allocate more money in percentage terms to the NHS than most other areas. There are always a few deviations, but the NHS tends to get more than other government departments, and then it tends to get topped up as well. So the NHS, as you mentioned at the beginning, is absorbing a lot of public spending and an increasing share. So it's definitely not true that what's happening now is being driven by NHS cuts. NHS spending in cash terms, but also in real terms, so adjusting for inflation, is increasing and has just consistently increased over time. Now, there's always a question of, is that enough? Does there need more? But I think the basic fact is there is a lot more money going into the system. And as I think we'll talk about, money matters a lot. And, there are lots of financial pressures, and how you allocate the money to different places and how you design the incentives and the payment flows matters. But actually getting value for money also really matters in terms of what you're getting out of spending that money.
It was worth underlining that the NHS really has got a lot bigger. I think in my lifetime, it's roughly doubled as a share of national income. So, as you said, very much the golden child. The state is doing more and more healthcare over time. So, there could be a case for even more money, but this is not a case where the NHS is being cut back like other services. But let's talk about value for money, I guess more broadly about productivity. So as Max was saying, it's not just about what money you put in, it's what you're doing with it. And what everyone would love is a more productive system where for any given money you put in, you get more of something, whether that's longer lives or healthier lives or whatever. I know the government has ambitious targets for productivity. So maybe tell us what the targets are and how's that going?
Yeah, so I think, as you mentioned, both this government and its predecessor have talked a lot about NHS productivity, and for the good reason that almost every metric seems to show NHS productivity almost falling off a cliff about 5 years ago and not yet recovering to where it was in 2019. And so in concrete terms, that means, as we've said, funding, inputs and other resources the NHS uses have increased a lot, and we are delivering more care. We're delivering more healthcare than ever before. But this increase has been slower than the increase in funding. And so that means that for each unit of care that we're kind of providing to patients, we need to put more into the system. And as you said, if we could undo this, then with almost any level of resources, we'd be able to deliver more healthcare, have better outcomes, and we'd have a win all round almost. So this government has set specific targets for the NHS to improve by, I think, 2% productivity growth each year over the course of this parliament. And the good news on this front, at least according to the estimates by NHS England, are that over the last 18 months, this seems to have been happening. And so we've been able to deliver lots more healthcare than we otherwise would have been able to. The jury's still out on exactly how we measure this and whether this can be continued for the rest of the parliament. But broadly, this might be a good news story that we're going to continue to be able to deliver more and do more with the resources we have.
Okay, so big picture, make sure I got this right. It's a big picture, pandemic comes along, NHS gets less productive. So if given money going in, it's producing less. In the last 18 months, it's starting to turn around. So the NHS is getting more productive in the sense that it's providing more care, so maybe more appointments. But Max, how does that square? We just said that the waiting lists aren't coming down very quickly. So what's going on? So the NHS is getting more productive in that per pound it's producing more, it's paying more doctors, it's producing more appointments, but that isn't translating into big waiting list falls. Is that the right picture?
That's exactly right. So the NHS is getting a bit more productive, but it's still less productive than pre-pandemic to start with. But you're right. In some sense, the government set this productivity target kind of as an instrument for achieving all of its other targets. And it's done really quite well, it seems, on productivity. Productivity is above target in terms of growth. But as you mentioned, the waiting list is falling really quite slowly. So that's a bit of a puzzle there. Why is that? And I think we've looked into this, of course, and the reason seems to be that, yes, hospitals are more productive and therefore they're delivering more activity. So, they're doing more surgery, they're doing more outpatient appointments. That's happening. But at the same time, we're not seeing as many more people leaving the waiting list. So we're doing more activity, but not as many people proportionately are leaving the waiting list as that increase. So what that means is that people, when they leave the waiting list, are receiving more care. Maybe they're getting an extra outpatient appointment. Maybe they're spending more time in hospital. So we're getting more activity, but it's not translating into corresponding falls in the waiting list. It seems because people are receiving a little bit more care.
Is that a good thing or a bad thing? Sometimes put like that, it's like, it's good. I get another appointment, I get more care. Maybe I'm better off. But is it unambiguously good that people are getting more care? Or is it that there's more complex case, people need more care for the same outcome? Is there too much care in somebody? Do we know anything about whether that's a good or a bad thing?
So the short answer is we don't know, but I think it's worth thinking this through a little bit because I think this is hopefully going to be useful to think about. So if it's because people are genuinely receiving higher quality care, that would, as you say, probably be a good thing. If it's because there's greater complexity, people are more complicated, that's not great, but, the system has to respond to that. It's not obvious that this is all driven by greater complexity, that might be playing a role. The other option, and the more concerning option, is that something about the way we've set up maybe the financial incentives in recent years, maybe something else, means hospitals are doing more activity that isn't actually that useful. Patients are getting it, but they're still leaving the waiting list like they would have done before. In that world, it starts to be a bit concerning that this big increase in activity isn't translating in some sense into outcomes. And as we've talked about earlier, it does matter how hospitals are translating their resources into activity. Like a factory, we want a factory to be more productive and to produce more. But we do also care about the value of what's being produced ultimately. And if this extra activity isn't as valuable for patient healthcare, for them leaving the waiting list, well, then that is a little bit of a cause for concern.
We should talk about system design, shouldn't we? Because that's kind of the point we talked about earlier. The point of the NHS is not to employ doctors or nurses or to create appointments or to buy CT scanners or any of those things. They're all inputs into something else. What we ultimately want is a healthier, longer living population. The government can pump money in, it can try to do more activity, but actually it wants more of those outputs. That really depends on how they design the systems, the financial incentives, the structures. So the government is planning here, Ollie, to change the NHS. They've got this big 10-year plan. Give us a kind of a brief summary of how we got here and what they're trying to do in their 10-year vision for the NHS.
Yeah. So as you mentioned, last summer, the government published its big 10-year health plan for the NHS. And this was kind of a big wide-ranging document broadly setting out their vision for how they'd like healthcare to be delivered by the middle of the next decade. There's far more in there than we can go into today. I'm sure we could spend a whole podcast series talking about it. But broadly, it was organised around these three big shifts that they often talked about. So that's first a shift from hospital to more community care, second a shift from analog to more digital technology, and third a shift from sickness to prevention. So in kind of big picture terms, this is about less traditional hospital-focused reactive treatment and about more managing health close to home, maybe with better monitoring and diagnostic tech.
And in principle, on the face of it, that sounds good. I mean, Bax, do you think it's a reasonable plan? I mean, is that a reasonable vision for the NHS?
I think there are a few parts to this. I think it's not a surprising plan, I think is worth starting with. That kind of big picture vision of more community, more prevention, more technology. There's a broad consensus, I think, both in the UK over time. Many governments have tried to do exactly these things, and actually across country, that these are kind of sensible approaches broadly. You know, let's think about technology. Using better technology, improving productivity that way is more or less unambiguously good if it's done in a sensible way. So that broad consensus is there. It's not a huge surprise. I think the challenge here is what makes it different to those previous plans. As I said, many previous governments have tried to implement these things. These are big changes. The 10-year health plan is really a big picture look of what would the NHS look like in 10 years' time. There's a lot of ideas in there. I think the challenge is actually implementing them and actually prioritizing them. As we've talked about, the NHS is under a lot of pressure. There's more money, but there clearly are financial constraints here. Things are struggling. How do we actually get from where we are right now to actually that wonderful NHS that we would all like in 10 years' time? That's the really thorny question, I think. And that's the thing that the 10-year health plan didn't really tell us about. There wasn't much focus on prioritization. What are the 3 things we're going to do? We recognise there are trade-offs, but we've decided these are the best ways to start. How operationally are we going to implement these things? Wasn't really there in the plan. And so while big picture, it might be a pretty consensus view of what the NHS should look like in the future, actually getting there and actually changing the system to get there remains an open challenge.
Said like that, it sounds like it's not really a plan. It's a vision for an end state, potentially, but it's not a plan in the sense of then we're going to do X, Y, and Z, and that will lead us to this place. So instead, what does the government need to do next? It sounds a bit like they've got a vision and they're cracking on, but have they missed a step in some sense of actually picking, like you said, picking a priority or saying we're going to do this rather than this? Or is there something missing in their plan?
I think you're right that this is a vision, not a plan in some sense. I suppose, what would you concretely want to see? I think you'd need to see the roadmap of how you get from here to there in a kind of plausible way of, okay, in 2026, we're going to concretely make this progress against these 3 things so that when we get to 27 and 28, this is all set up. So by 2029, we have these few things going. We're getting in that direction. I think that's really important here. Now, this year, we're going to see the publication of the workforce plan, the new long-term workforce plan after the old long-term workforce plan in quite a short term was got rid of.
And that's basically the plan for how the government's going to make sure there are enough doctors and nurses and how many types of staff they're going to have and how they're going to train them and that kind of stuff.
Exactly. And in some sense, if you're going to spell out how many different types of staff and where they're going to work, that presumably will require actually setting this out a little bit more. So perhaps we will have more information later this year. But at the moment, I think, as you say, it's pretty high-level vision still, trying to do just a lot of things.
Yeah, and I think as well, there might be a bit of a tension between some of the stuff we've been talking about here about the medium-term, community-focused NHS that they set out and some of those shorter-term waiting lists and things that we were talking about earlier on. If the government really wants to, by the time of the next election, be able to say, we got waiting lists down, we did lots of elective activity, we had a big focus on hospitals, that might actually pull you in quite a different direction to we're going to focus everything on primary care and preventative care. And it's that type of kind of trade-off prioritization that we haven't yet seen lots of.
Yeah. And that could be particularly challenging in this situation with like kind of big fiscal constraint where actually this prevention stuff you might be able to invest now in the future that'll have a payoff in terms of getting fewer people on the waiting list for other conditions. But there are still people for whom you didn't prevent their problems and they now you've got to fix the problem. So there also could be tensions there. Should we look ahead for the rest of the Parliament? And obviously, that's the government's going to really care about what happens between now and the next election and how people feel. We've talked about there will be some central plan that they've kind of got about changing the NHS. More money is going into the NHS. We'll see if even more money goes in at the next spending review. None of us will be surprised if we get to the next spending review and actually find some more money for the NHS because it needs some more. will be a workforce plan the government will set out, how many GPs I guess it wants or whatever else. But of course, no one knows quite what will happen. There could be an optimistic and a pessimistic case. So why don't you take the optimistic case, why don't you take a pessimistic case, and let's work through what the upside and the downsides might look like. So maybe Ollie, talk to us about what would an optimistic vision for the NHS look like in the next few years?
I think the best case for an optimistic outlook here is based on the kind of good news about productivity that we've seen over the last year or so. So ultimately, this isn't going to be a period for the NHS like we saw in the 2000s, where things got lots better because lots more money was being pumped into the NHS. Ultimately, the fiscal constraints that we've talked a bit about here mean that if things are going to get a lot better, it's going to be because we spend money better and improve productivity. And if we can keep improving productivity as we have over the last 18 months, whether that's through more technology, more prevention or other things, it's very possible that we keep gradually, unspectacularly, but kind of incrementally making things better. I guess as well, there are some people who are very optimistic about the possibility for new technologies to really change the NHS. So whether that's new drugs like weight loss drugs or artificial intelligence making a big difference to how the NHS works, there is a chance that can make a really big difference to how smooth things run. And I guess more generally, we've seen that as we work through some of these backlogs and immediate crises that we saw at the height of the pandemic, some of these things might get easier day to day. So I think the strongest case for optimism isn't that everything's going to be brilliant overnight, but more that things will kind of gradually get slightly better, and we'll be here in 3 or 4 years' time saying, actually, the peak of things was just after the pandemic, and then things got better.
Okay. So possible to have some good news. So the government implements its plan, it makes some progress, it has higher productivity, that actually translates into better outcomes for people. Maybe technology helps, people's weight reduces and that helps. So there is a optimistic case, Max, but there's also the pessimistic case. So tell us about that.
Right, I'll try and take a pessimistic view here. I think it's worth saying that like a reasonable pessimistic view isn't that bad. This is not, I don't think a reasonable case is the NHS is going to fall over tomorrow in a way that during the pandemic we really were worried about. I think a plausible pessimistic case is we more or less keep muddling along as we are, and we're all sat around here in 2029 essentially saying pretty similar things. They got a little bit better, but it's still quite a lot worse than pre-pandemic. And like Ollie, I think productivity here is crucial. So productivity growth, if it doesn't continue to grow quite rapidly, and that is plausible, it might be there were some easy gains we could make, and actually productivity growth now slows down. So given the tight fiscal situation, not great productivity performance, we're going to have a decade of productivity lower than pre-pandemic hospital productivity. That could really translate into only very incremental improvements in performance. Similarly, as we've already talked about, if not much of a 10-year plan really gets implemented, or there's challenges implementing it, if everyone's distracted by other things, that is also not going to help here. And I think the final one that loyal listeners will want me to mention are the fiscal challenges. The NHS we've talked about is relatively protected fiscally, but that doesn't have to be the case. We know there are lots of pressures. We know there might be pressures on defence spending, on social security spending and other things. And there is a world where we get to the spending review next year and the government decide actually we cannot afford, or we don't want to prioritise such increases in the NHS spending. So productivity disappointing or spending coming in lower than planned, both of these will continue to limit how much performance can improve over the rest of this parliament.
Yeah. There's some subtlety there as well, isn't there, on the spending review? It might be the case that actually we get the spending review, maybe it does get topped up, but not by enough to, think about the weight loss drugs. That could be an example where actually you need quite a lot of investment up front. They're very expensive drugs, at least at the moment. You might not see the sort of cost-reducing benefits of those until much later. So actually, it might be that to fully do more prevention kind of stuff, you just need a lot of money up front. And actually, maybe we're not going to deliver that. So even if they get a above average settlement, that still might not be enough to realise some of the benefits from prevention, for example.
I think that's right. This is quite sad to say, but I think a structural case for pessimism here is the fact that a lot of these benefits are long-term. A lot of the things in the 10-year plan, if they work, require upfront investment, long-term benefits. The weight loss drugs, perhaps, as you talked about, improving NHS IT, improving capital, requires long-term commitment, long-term planning so that we can do some upfront challenging things credibly do it so that we get to a future where we are actually going to get the benefits of that. And if that's not going to happen, again, I mentioned we got rid of a workforce plan that was meant to be for 15 years. After 2 years, capital allocations for hospital planning just constantly getting moved around for many years now. That makes it quite hard for some of these long-term benefits to be realised.
Well, they're not long-term plans if they get scrapped after 2 years, are they? But the way you phrase that, Max, has sort of invited me to ask the type of question that I hate being asked because I haven't got a crystal ball. But if you had to say now, do you think it'd be more likely to be an optimistic or a pessimistic scenario at the next election? Are we more likely to be saying, actually, we're surprised on the upside, this is looking a bit better than we thought? Or, oh, this is actually still a bit of a hard slog? What do you think is more likely?
It's a tricky one, giving me a binary, so I can't say it's right in the middle.
You could if you want to. But
well, I think my central, and this is crucially my central expectation.
The max central expectation.
The max central expectation would be that we trundle along nicely, we get a bit improved performance, we get to the election, and the NHS is definitely not at constitutional standards, but is somewhat close. It's, say, halfway between where we are now and there. Some things have got better, technology, the NHS app and things like that are getting better. It's easier to access GPs. But some of the big structural stuff about how we're going to organise care, how we're going to organise and pay providers looks pretty similar. And ultimately, the NHS is in a bit of a better state than we are right now, but isn't fundamentally very different.
That's not awful as a central case. It could be worse. But on that, we should probably wrap up since we covered lots of ground today. I think it's worth remembering back in everyone's mind that the NHS really is big. It's big in terms of how many people it employs, how much money we spend, and obviously it's big in terms of the role it plays in the quality of all of our lives. Money isn't everything. We said that the NHS has been the golden child of public policy for a long time. It tends to get an outsized share of government money, and that has big implications for everything else, but money isn't everything. And if you roll forward where we think about big pressures of ageing and chronic disease, there'll keep being a pressure on the NHS. We have to find ways to make healthcare more productive, which means thinking about the system and how it's designed, the financial incentives, the structure, the role of prevention versus cure, and all of those things that we've talked about. That is going to need some long-term plans. That means plans that aren't scrapped within 3 years of being written. We actually need to have a plan and follow through. And that means we need to make some of these big picture trade-offs, not to have a vision, but think about if we're going to do more of one thing, are we going to do something else? Are we going to prioritise doing one thing first over something else? So the government needs to really grapple with that. And I think we as the people who love the NHS need to remember that we shouldn't be expecting to get to a point where there aren't constraints. I think it's natural that everyone wants more healthcare. As we get rich, we want to live longer, healthier lives. But all systems ration healthcare. So in some sense, the big choice for us is not just how much money we pour into the system, it is what kind of care do we want to give for what kinds of conditions and for what kinds of people. And no amount of money or productivity improvements will get around those choices. So there is a big choice for the kind of system that we all want the NHS to produce. But on that, let me say a huge thank you to Max and Ollie. A thank you to all of you for listening. If you've enjoyed this episode, please do share it with people you know. And if you want to become a member and help support the podcast and other such outputs, you can do so for as little as £10 a month. You can check the link in the episode description. But for now, thank you again, and we look forward to seeing you next time.